today, I think in a success of the lectures, this I think is a fourth. I chosen the topic as a very important importance, as you have seen that COVID fallout has killed so many people. And whether it is the COVID kill or any associated infections is not very clear. New documentations are coming. Let's go ahead. The topic is intensive care unit associated infections. So a patient in a intensive care unit is risk for many reasons. You can just see the patient is overshadowed by many things around. You can see in the picture, the real person is in the nurse handling the matters. Next is life at risk. We should find some possibilities, make things better. That is the aim of it. We cannot give up the hope because even in a desperate condition, many people get admitted ICU for the well-to-do people. But the people with the poor and all, what really happens, you all know very well, better than anyone. So one thing is, one of the articles I was reviewing, so there was a very nice quotation by the Einstein. He said, the education, not learning of facts. We read lot of things theoretically. If you open the net and you put intensive care units and you are bombarded with the maximum number of articles. But the training of the mind to think, this only can save the people in ICU or any dangerous circumstances, because we are training the students more on the theory than on the practice. And the practice also comes by with the experience, seeing multiple number of patients, effective documentations, and they should also know who lived and who died, also gives a lot of knowledge. When ICUs are created in order to look after the welfare of the patients that need ventilators, blood pressure treatments, and the close monitoring by doctors and other healthcare, better nursing. You just see, it looks like a dreamy world for everyone, but inside is the facts which are very essential to think about. It is hardly the case that everyone admitted to the ICU is on the verge of losing their battle to survive. See, this is the greatest hope to anyone. This is the principle which now the emergency medicine has become the very top priority in many hospitals. And no hospital can be run without some ICU beds and all. It is becoming mandatory. So really what it means. So they may not give a permission to a hospital unless you have an emergency care. In fact, one study suggests that more than half of the patients admitted to the ICU have an exceedingly low risk of dying during their hospital stay. This is the hope of the people. See, 1 month I have seen in one hospital, out of the 20 people admitted, 18 people died. Just imagine. Then it creates a very bad image of the hospital and around, and even the staff working there will tell, no, it is very bad that ICU care and all last month very dead and all, but it is not this one. So even any disease is living with a hope only. So the most important thing, once again, we are coming to the pre-independent era or whatever you say, that when medicine, prevention is better than cure. This is a very important thing. This all means everything, the life of a patient, more than 70% depends upon preventing an infection. Once you cannot prevent an infection in the ICU, which is maybe inevitable, but the death is going to hunt the people. And why do they come to ICU? This is a very important thing. Now, there is a lot of controversies. I will be just going a little thing to explain. There are also a lot of litigations. So they say that once you go to a casualty, people are putting in the ICU. Is it for making a money, or there is anyone, just a junior resident there, puts the patient in the ICU without any evaluation of the patient? There the people, the conflicts, you see a lot of attacks on the doctors and all these things. This is the most dangerous area of the hospital for a life of a doctor or nurse, is the casualty, where one has to make a good decisions that we can talk on one day, how dangerous is, how helpful casualty can also be. So the most important thing, we have put a lot of patients in the COVID is the ventilator support. Many people died with the respiratory, the oxygen shortage. More than the ventilators, there is the oxygen shortage. And so many people during the treatment died because the oxygen tanks and hemodynamic support, shock. A mother has bled, lot of bleeding and brought to the hospital, and she will be put on lot of blood, or somebody has met an accident and lost about 1 or 2 liters of the blood. Then is the renal failures, severe acidosis, monitoring neurological dysfunction, hematological disorders. So a patient with a stroke, there is nowhere he can be treated, at least in the. What is the obvious focus is community-acquired pneumonia also are entering into the hospital. Patients come with this thing. Even there are now pneumonias are only hospital acquired. Now the community acquired. So, but suddenly a 70 years old person becomes breathless, streptococcus pneumonia. They may enter in acute CS meningitis, urinary tract infections. It looks very simple when you don't handle properly. See, one of the causes of the going into the septicemia is a urinary tract infection mismanaged. Abdominal focus of infection, some abscess, wound infections, and trauma with infections. So you see, this hospital, the world aim is to make it green hospitals, but at the same time, there is no difference for the microbes, whether you paint green or not. Nosocomial infections are major cause of avoidable morbidity, mortality, and the extended length of stay. Prevention of this is the key. Continued surveillance, audit, and hand hygiene are therefore vital. See, we must have now there is a lot of things, and I think many of you are very antibiotic policy, infection control committee, what they discuss and all. They should be very frank about it. Because many times we try to hide. Now there is also a lot of things going on there about how to construct an ICU, where to construct an ICU, and suppose you have a cath lab, and can you put an ICU there, and all more controversies are arising. The recent introduction of care bundles grouping, best practice for the invasive devices. So the man lives by the help of a device. This is a very important. You may have 4 devices, 6 devices, and all these things. So they are making, all of you are very well senior practitioners. They know they are creating bundles, and all the nurses are trained in that one, and they have to make a checklist. And if you are using certain bundles prescribed, I will be going into the very basic things. I'm not a specialist in emergency medicine, but I used to always go to the ward whenever there is a serious report comes, a resistant, this thing after a transplantation of the kidney. I used to go to there and see how the practical assessment is very essential. Microbes involved tend to be more difficult to eradicate due to increasing microbial resistance. This is a very important thing and all. You go to think about most of the doctors there and all these things. Most of the doctors exhaust many things. Many of you may be using 4th generation, 3rd generation, 5th generation cephalosporins and carbapenems and colistin also. So what is there left for the patient when you admit? This is a great question, because we don't have any control on anyone. Anybody can use anything. Even if you go to a village and the village practitioner or whatever you say name to him, he is imitating the prescriptions of the super specialist, and he is treating. This is what is the greatest tragedy in this country. What this many quacks are doing is there. So a patient went to a hospital, became very serious with the COVID and all. They're imitating that prescriptions, and they are writing. This is one of the causes a tragedy, because we blame the ICU. It is not the ICU which can save, because patient has already entered. Please remember, as a practitioners, if you are using all the broad spectrum antibiotics, you calculate the incidence of death or prevalence of the death, you find very highest, very erratically treated. So suppose if you are not going to use very extended spectrum of distinct chances, particularly, you see recently, we are not seen in the history, in the recent 100 years, many people died with the pneumonia. This is also, it is not that in COVID, but if you take obituary of the many people from US and all, they're all dying with the pneumonia, with the fungal infections. That means they're exhausting the antibiotic line, and their fungi are these things. As you know, black fungus has become the great tragedy recently. Timely recognition, management of this condition is key to providing best care within the ICU. The focus of therapy should always be targeted to specific microbes. This is the one thing is there. If somebody is admitting a patient in ICU without a proper microbiology department, so ultimately after 2 to 3 days, it will be, there is no use of a treatment and all. It becomes a salvage treatment. That means you are giving everything in a good hope, but not scientifically this thing. And you take the prescriptions of the person when you are using this thing. More than the cost of the hospital, the antibiotic bills will be more than the 2 to 3 lakhs. That means we are going and we need a good setup of the microbiology and needs to be. And now they made a little calculation some time back. Even 10% of the beds are ICU. More than 20% of all nosocomial infections are acquired in the ICU. A paradoxical thing. You have only 10% beds in the hospital of the ICU, but 20% of the hospital associated infections are morely acquired in this one. And not only expenses, you take to a country like India, who pays for what? This is a great thing. And many people in between, they take the patient away when they are not able to meet the money. Contributing the serious of the nosocomial infection is the increasing incidence of antibiotic resistant pathogens. I already told they're called as superbugs. Bugs become superbugs. And now looks very smartphone like that one. These are all the advanced. They are becoming. They can fight any antibiotic. That's what we have created now recently. Patient in ICU have chronic combinations. It is not that a patient admitted with 60 years. He may be diabetic, he may be renal failure, he may be a cardiac patient, he may be on 10 types of things. High frequency of use of catheters provide a port of entry of this thing. And multi-drug resistant, even whatever it is there, basic organisms are very important. Even MRSA can kill. You know that we have antibiotics like penicillin not working, vancomycin. So many controversies, linezolid. After that, what we are going to give to this? The purpose of this program is to maintain a healthy and safe hospital by prevention and control of the healthcare, surveillance and investigation of the infectious disease, public education. This is a very important thing, and everybody should know now. Most conflicts, litigations, and cases are arising in relation to the ICU care. Even public should be educated on this one. It's not that you put into ICU care means that they will donate life. No. It is not at all donating life or improving the life, but it is only sustaining the life with the possibilities. Education programs for the employees, volunteers are one of the methods. This OmniQuiz, whatever it is doing, they are doing a lot of contact. I was talking to Shobit. This is a very important. This is the situation of a hospital ICU care. You just see that the jam packed with the patients and all. This is you can mean to many cross infections and all. If the next person is having a serious infection that we are not able to maintain in many public institutions. So above all, what is the danger of these people? Sickliest persons they are putting there. They move less, malnourished, more accused, maybe associated with the diabetes. Recently, there is one Army colonel has called me to say about a patient admitted in a ICU in Delhi, and they have discharged the patient after started getting the bed sores, and they have not looked at it and discharged. When he came back, they are not admitted, and they went for a suit, and they got about 50 lakhs as a compensation because they are not taken care of the patient, and they are not taken back the patient when these are all the litigations with this thing. And we have to document all these things. When a patient is admitted, how good is that? There is some glasses scan. I am not a competent person to take up. What is the status of the patient? If you are not going to document, you are going to get into legal litigation. What the law believes is there, what you have documented. So you have to write from the case. So many junior doctors, maybe very young learners, and they don't document and they write just a very shabby way. They write it. that means the patient is all right and the patient died and you pay the compensation. This is very important. And please remember, documentation by the seniors or done by the juniors have to be signed by the seniors. This is where the ICU, if you take about 50% of the litigations and fights are at this level. More invasive lines and procedures, including the surgeries, long length of stay, more IV and parenteral drugs, more tube feedings, parenteral nutrition, more ventilation. Just see the patient is hanging this one in a situation like this one. Hand washing facilities are inadequate. Patient close together on sharing rooms, understaffing, preparedness. Please remember, this is very important. Most of the ICUs are built as just a rows, and there is no place for hand washing and all. Even though we emphasize 100 times, people depend upon the alcoholic, but I don't know how long alcohol makes it more. No separation of the clean and dirty areas, excessive antibiotic use, inadequate. See, you are shifting some septic patient, a gynec patient, and then you are putting into a general situation of the shared by 4 to 5 people and all these things. You are inviting these things, and they are also advising to keep a septic rooms. That is happening also now. And the most important thing, which an elderly person, please remember, I was always emphasizing, urinary tract infection is the most important for an elderly person. And sometimes they don't have any control. You are putting a Foley catheters. And it is a questionable how many people are well trained, even the postgraduates in, if they are given a question and are going to demonstrate, we have this thing. The many people end up in the ICUs with the urinary tract infection, where you have to train with the videos. And next comes the lower respiratory tract infection, skin necrosis. Suppose I told you that it is just bed sores, and staff are less, and they are not moving the patient frequently. What happens? Then the patient will develop a bed sore. And it will be, the smelling of the things and all, then it will be a big havoc in this one. Bloodstream infections, you are putting a catheter, and sometimes somebody may get operated and become septic and come. And clean and decontaminate all equipment after use. All the equipment, disposables, non-disposables or anything need high attention in this thing. Sterilize or use high-level disinfection, rinse and dry items that have been chemically disinfected. Package store, this is not this thing and all. This is a strategy of the nurses, how to take immediately that equipment. Intensive prevention of the bloodstream infections. This is very important. Suppose somebody is putting a cannula there. So strict attention to the hand hygiene. This is a very important. Suppose you are putting something into the neck, a jugular vein or an artery. Then what happens? If you are not caring this one, you are directly injecting the infection into the heart. And you should be sensible to prevent this thing. Aseptic techniques, disinfection, sterilization of the items, education of the staff, infection control level, keep environment clean, dry, dust free, surveillance. No, and you have to have that. I will be coming at the end of it, how much this one. So you please, a simple thing, many of you may be working in a very deprived conditions or anything. Whenever you insert any cannula or anything, just prepare the skin. I told you chlorhexidine 2% is isopropyl is very much. And there are some articles you can see how you just clean area, pinch the wings on the application and apply, press the sponge. These are all not this one. Bloodstream infections, septic pulmonary emboli. So these are all the things can happen. So suppose you get a patient with a stroke, and then you can develop vegetations may dislodge and produce a stroke. It also can produce metastatic infections, particularly the leukemia patients go into multiple complications. So chlorhexidine, just for all this thing, all of you must be using and all these things. I told last week also the betadine use and all these things. So if you are using a good antiseptic, and chlorhexidine is found out to be even for washing hands and all these things, is a good thing. So if you take you are putting a drip and all these things, and injection ports, you may penetrate and all these things. These are all the junctions where a patient can get infected. Next, you see patient's own skin. From here, if you are not cleaning properly, the bacteria on this one, Staphylococcus epidermidis, Staphylococcus non-coagulans, through this they can enter into this thing. And the contaminated entry port, contaminated disinfectant solutions invading. Don't think that one we have to use everything and all. This is one of the things. Catheter-related infections are becoming more and more. When the more you use, the less you staff you have, then they lose patients and they don't do it properly. You may do it properly, and another one you are not going to do it properly. And see, the most difficult thing is there. I always tell, if a patient to be saved in an ICU, 90% depends upon the staff nurses. You take from anywhere and all these things. Doctors can give you instructions. Doctors cannot supervise. They are now, if you see with this emergency, it's hardly difficult to get a doctor getting. There must be a written protocol by the trained staff according to the written guidelines. Sterile procedures you have to use, because sterile gowns, sterile gloves and all these things, antiseptics and all. See, in China, when the epidemic became so much, the people went inside the ICU. They never came out till the evening, and they were using diapers. That things are not possible at all in a country like that, India, where we cannot accept that one. Suppose once you go out or do something which is not in that field area, suppose you may be wearing a gloves, after 10 minutes, you go and touch something with you take a bottle open to take some injection and all, they get and all that you're this thing. So once again, I am emphasizing chlorhexidine is and also somebody suggested in Lancet, drying time is before insertion is very important. I put Mackie DG et al. Told that you just not applying. You may be with 100 things, still you go to this thing. If you don't observe it, no difference. That is not. And prevention of catheter related. Do not replace it routinely. Just think about it. This is all the bundles gives. Replace it if it is inserted in an emergency. Suppose you can take the catheter. Suppose somebody comes to the casualty and put a cannula, and it may not be very hygienic. Then you can immediately coming into the ICU. Then you can remove. If not functioning, in this thing, general handling. And these are all the things you can look into this program and all. This is a very important points I have written. This all makes, suppose if you are meddling unnecessarily, it is dangerous. And if you are not caring when it necessary, also it is dangerous. And actually many of the Western countries, they have put a very much observation at this cannulas. Cannulas are one of I told you, urinary catheter cannulas, they are usually directly injecting if you are not careful. And if you ask me, you vote for the best, I vote for the person who is taking responsibility of inserting this thing. Suppose we may talk about 10 types of organisms. It may be a postgraduate discussion, but the end you cannot do it unless you have a trained staff in doing a phlebotomy staff are employed. If you take 70% of the Indian hospital or even 80% doesn't have any trained phlebotomist. Only some centers like CMC, some good hospitals in South India, they have got a dedicated phlebotomist, this one. And see, if you have got a very good phlebotomist working at this area, certainly they found out there is a great reduction of the death of the people. See, these are all the things which the clinicians decide, and the emergency. If there is any phlebitis and all these things, you have to look at all the places where you are put a cannula and see the redness and the early signs of inflammation. It is not that the patient is put under a blanket, and that means you may be missing a lot of things going on there. You see in one of the hospitals I have seen, almost many of the area of the skin has been this thing. So I told you one thing in the beginning when I told it, it is not that a microbiology lab can save or anything. It is only the point of entry. This is a very important. At the point of entry, you have to document what is there. At the point of entry where you are putting a cannula, you have to be careful and you have to be watching. You put a cannula about 3 days back and forget about it, you find a lot of necrosis, and the patients will be telling that everything has been leaked, and this always happens even whatever good you are. And for topical mupirocin and all they are using, there is a lot of things. There are some antibiotic coated things are also coming, and there are some mupirocin is effective. It is a very popularly used whenever this thing. There was this thing, Michigan Keystone Project study, they made it basic intervention. So you suppose a new nurse joins, the most important thing they train is hand hygiene, full barrier precautions during insertion, skin cleaning with the chlorhexidine, avoiding femoral site, removing unnecessary catheters, use of insertion of checklist, promotion of the safety culture. This is the last one is the most difficult. Who is responsible for that one? See, recently to get a infection control nurse is also very difficult in many hospitals. You look into this one. The life of a person, this is why I have taken Michigan Keystone Project. They worked on this one. They found out that if you are going to train these people, and also you may be knowing when Obama became the president of the United States, there was a less number of nurses or demand from the India at that time. Suddenly, what he said is the Obama administration. You don't need a very much postgraduates and graduates. You take an intermediate or 10th class or 11th class or just a PUC person, train them in these areas and make them experts. All through life, they will be specialists on all this thing. They found out with the postgraduates and graduates and postgraduates, and not even highly qualified, but trained in this work, they became the excellent results are produced. They changed a lot of health policies because of shortage of nursing. Please remember, this is the topics they have taken to train the people. Urinary catheter is the most important. You see, the most, if you take to the genital region of a female, it is very unclean when they admitted, may not be having a bath and all these things. Lot of flora are lying there. So pause catheter when bladder is full, this is a very important. I want to tell you, if somebody is putting a catheter when I empty this one, it becomes a very painful and you are going to traumatize. Before catheterization, prepare the urinary meters with the antiseptic, if iodine is there, hexachloroquine, inject single-use sterile lubricant gel, lidocaine into the urethra and hold there for 3 minutes. Suppose if you are not going to, suppose the patient is very sensitive, if you are not using a local anesthetic, patient will be irritable, not cooperating, causing this one. Use sterile catheter, use non-touch techniques for insertion. It's a very entirely, see some of the slides which are moving last 1 or 2, 3, this all makes the, in my view, whenever we made an inquiry into the gross deaths into this one, there is a gross lacuna in these areas, whether inserting a urinary catheter or a cannula, central lines and all these things. If these are all taken care, suppose you are putting a patient, see a patient has come for a delivery healthy, and a very careless insertion of the urinary catheter is done, because if a genital region is not properly cleaned, all the microbes around the genital vagina, they all enter into the bladder, and directly by your inefficiency, uncleanliness, you are creating an infection. Finally, this patient may land up in ICU and even may die also septicemia. Some at least 5% of the septicemias are associated with arising out of the urinary tract infection. We just take it as some antibiotic, we take it, but even urinary traction is life-threatening. Do not disconnect catheter unless absolutely necessary. For urine specimen collection distinct outside the catheter problem, see, this all I cannot be, this one and all. See, if you go to a hospital where there is a person, you to a public institution, if they want to collect the urine patient and all, they will just open that bag and they will collect the urine and all these things, and very carelessly they are not put, and sometimes they clamp it and they forget it, and it causes the regurgitation and a grat of pain and all. Keep the bag below the level of the bladder, because you see, when there's no picture there, in some other pictures are there, when you are taking a patient from one ward to another or this one, what they will do is they will take that urinary bag above the patient umbilical level. That means what is happening, the urine is going retrograde and there will be certainly colonization of the bacteria. So it should be at a lower level. This you find a grass happening around us when you are going through this one. One patient is pushing from front and another from back, and another is holding at a high level like a blood drip which is going on. Please remember, this is one of the very bad scenario you see. Empty bag every 8 hours or earlier. Do not hold bag upside down when emptying. Collection of the bag never must be touch floor. Always wash, disinfect hands yourself. Use a separate disinfectant jug. Nosocomial pneumonia. This is a very important cause of death. And I put the first sentence. Consequence of a hospital-acquired pneumonia is very dangerous. That's what has happened in the COVID. And then see in the mortality report, the death certificate, you find many times you are not writing properly. We write a cardiac arrest or anything. But what is certainly the additional morbidity is because of and it happens even whatever care, prolonged hospital, long-term physical, developmental and neurological sequelae. Suppose somebody is admitted with a stroke, he is not cooperating and he is not moving and he is not incoherent. These are the people ultimately develop. A neurology patient develops a pneumonia and dies. This is what the scenario you find in most of the strokes and all. He won't die because of the stroke. He dies because of this thing. Increased cost of hospitalization, above all the death. So if somebody has got this is a very, very important, highly as this one, it is published, even though it is in 1986, stands good. Urinary tract infections are the most important. That's why I emphasize, suppose if you have got a junior doctors working under you, let them get trained from the lot of YouTube videos are there. And I just want to emphasize one thing is there. Even so many sometimes a postgraduate do not know how to select a catheter and a nurses. And they have to take into so many considerations with their experience, meter size and the length of the penicillin, or age and all these things you have to take. So the most important cause is 45% urinary. Additional costs will be 13%. Surgical wound 29% and the cost about 42%. Pneumonia 39%. Bloodstream, and these are all even though less, but it is significant. So coming back to this thing, once again, I want to, this thing, there is nothing which killed, because I am emphasizing so many times, this ventilator-associated pneumonia was the most important cause. Catheter-related bloodstream infections, urosepsis, intra-abdominal infections, sinus infections, diarrhea. Last two things also can make a matter. And I just not made any slide or anything, but you remember, carrying the mouth of the patient on a ventilator is very important. There are people who are taking a good care of the oral cavity. They survived better than are neglected. The device-associated infection is an infection of the patient. These are already told. See, it was within 48 hours, the patient may develop a fever or a inflammatory signs. So risk factors, just for all the reminder and all these things. Suppose your tracheostomy is one of the things. Somebody has done a tracheostomy and you have to take care of the tracheostomy, that all the put to this thing. And intensive care settings, use of antimicrobial, these are all necessary. Tell the patients to encourage postural drainage, encourage to take deep breaths, cough, maintain an upright position, elevate patient's head to reduce reflux and aspiration on the gastric bacteria. See, one thing is that suppose somebody is regurgitating, what are all the stagnated, if you put a oral feeding and all the bacteria will be multiplying in the stomach and he regurgitates and he reaspirates and he dies also with the infection. So we have just not for microbiologists, but these are all the factors which are all, what I mean is that it is the management of the patient at many stages reduces the death. Suppose somebody has got a very severe myeloid leukemia, anyhow, he may die for, he may just prolong a time of life, but may not do it. But one thing is that this gastric, patients should have a watch, everything they, suppose somebody has regurgitation, certainly it has gone into the respiratory tract. That bacteria which are harmless in the stomach can become very dangerous in the respiratory system. So take care of the nasogastric. Ventilators, after every patient, clean and disinfect and sterilize the reusable components of the breathing. I just want to tell, there was one of my relative got admitted. They were not even having a time to clean anything. Patients are waiting during this COVID time, just one like in a queue. So there's no much time. There were a lot of issues. So in spite of everything, hand washing before and this thing, where clean goes, which I told you. Suction bottles also use a single disposable. These are all some of the things you can put it. And I just want to tell one example. I was working in Africa at about 12 o'clock. One person has developed he has got a pneumothorax, and one lung has already collapsed with this thing. So I have nothing. Just in the night, we have to use some rubber cup and take one saline bottle, put it to one small juice like this one, put cannula into that one, and the patient is saved, because we have to reduce the pressure and all these things. So we have to see how this is done, or it should not happen in another way. Nebulizers change. These are all the things now. The nebulizers have become, even in the villages also, the very semi-qualified people are coming, and this one and all. Please, this thing, when your the workload is more, and nebulizers must be sterile, and humidifiers, clean and sterile device between the patients. So these are all the important, a very strict one. I think how much there was some issue. One hospital, they said that they were not having a distilled water or anything. They are putting the tap water for the humidifiers. Somebody was telling in the investigation proper whether this water is contaminated with a fungus. See, when you don't do the things properly, you get a lot of doubts. At the end, you don't find anything. Better not to deviate from the path of this one. If you don't have anything, if you don't have sterile water or anything like that, even instead of using a tap water, somebody suggested, one of the doctor friend suggested in that hospital, just at least use some bottled Bisleri water. When you don't have, don't put the tap water. This is what I told in the third slide, what Einstein said. We have to work with this. There is no fixed solution in ICU. There is this talk is neither complete nor anything. It is only sensitize and to make your own ideas. There is no ideal situation when there is a life and death is there. So your common sense makes a lot of sense. Change oxygen mask tubing. This is a very important thing. So you are seeing that it has become almost, oxygen has become an emergency situation. A lot of political gimmicks and people blaming the one another for the shortage of not only the oxygen, even though oxygen may be available, but you are not changing properly, it can affect. Study of the efficacy, nosocomial infection control. CENIC project was published, validating cost benefit in this one. It was a very much change in the situation. They found in the US and all developed countries. This is called as the study of the efficiency of the nosocomial infection control. This is the first thing, has got a very good wide documentation and appreciated. And they analyzed a lot of deaths. And then one infection control. See, this is where we lack very much in this country. One infection control professional for every 250 beds. We don't have anything now. There's a lot of CMEs are happening. See, we may be, many doctors may be there today, and their training as a professional to preventionists are very few are there. But a hospital, suppose if you say 1,000-bedded hospital and at least 4 people must be going from there. That never possible in our hospital. Maybe some corporate, an effective infection control physician. Now there are so many of my friends and all, their MDs or DNBs, and they are leaving general medicine and they are going as the infection control because it is more lucrative and more challenge. And see, you have to make a report. This is where we lack also. Suppose I found some patient sample has been cultured about on admission or after 2 days. After 4 days, we find a resistant Pseudomonas. Our report is no more valued. They say we have sent 2 times and nothing is coming out. But third report has come as a resistant Pseudomonas. So if you can call the doctor who is attending, then you can definitely reduce. Anyhow, I am very happy. I had a very good physicians in Travancore Medical College who were consulting me for all the things many times. So this all means, so that means it is a coordinated effect. I cannot just give some suggestion and if they think what a microbiology is telling, why I should care. This is not at all. So antibiotics must avoid widespread use of broad spectrum antibiotics. Please remember, broad spectrum antibiotics is like a charity. Whether it works or not, we do not know. We serve the food in the hotel or something, festival and all these things. So, somebody may like it, somebody may not like it. It is not some distribution of bonanza of the antibiotic. Antibiotic is a specific drug which should be used for a specific organism. Anyhow, somehow we failed coordination microbiologists with the impress the doctors what to use, not to use. And then what has become, I use a broad spectrum. There is nothing like a broad spectrum and all this. Broad spectrum may be good when you don't know the medicine, a quack must be. But if you see, I told you also, by the time a person reaches ICU, he has very few possibilities and few antibiotics are there to serve him. Diagnostic problems. Bacterial infection and sepsis are responsible for the significant morbidity and mortality, as I told. In this setting, new diagnostic methods. Suppose some of your relative may be going to a ICU. Please make it sure that you should go to a hospital where there is a good laboratory setup. If there is no laboratory proper setup, then things will go wrong. Current diagnostic methods in present about the laboratory, I don't want to tell and all, much not there and all. So now all the modern hospitals, they are getting a bacteria. That means whenever a patient got an infection, you take the blood, but you must collect the blood before giving an antibiotic. That is rarely possible because by the time the person comes to an intensive care, he has been exhausted, all the antibiotics. So that antibiotics are also in the blood which is collected. They will not allow the bacteria to grow. See, this is a very beautiful bacterial system. Whenever there is a growth, it will give a light signal so that they open every 2-3 hours and they find that, pick that bottle and system has become. And then Vitek also, you can find out what is the different species and what specifically is. When an organism is cultured, definitive identification and such, these are all, see one thing, do not depend too much on the laboratory reports. By the time in India, we don't have any antibiotic discipline. You have already so many antibiotics are floating in the blood and you take the blood, but you take a rationalistic, there are some neutralizing agents and all, they're all far reach. Then also sometimes one may get a virus infection. We don't investigate much for the virus infection in a ICU patient. So this you find in USA. See, if in USA, you see the most cause of the death of the people in USA is either viral pneumonia or fungal pneumonia. They don't die much with the bacterial pneumonia because we are using so many antibiotics. Ultimately, once you eliminate all these things, fungi will come. Recently, there was a lot of controversy about the black fungus. They put a lot of colors into that one, but it is not scientific to say a color because they are a species, they have got a variation. Please take it from me. If you are listening, ultimately a person may come die with the virus, and the patients are also, even a person comes with a cold virus or an influenza lab technician or a person who is taking the blood or a nurse can infect. So the combined regular liaison with the local microbiology will ensure the best treatment. This is a very important slide. It's not the clinician is a superior or a microbiologist is a more technical person or anything. This is not there and all these things. Suppose if you want to get the ultimate success of saving at least 5% of the people comes with a good coordination with the microbiology. Then invasive fungal infections have become recently. Particularly these neutropenia patients are with myeloid leukemias when they give chemotherapy and all. Steroids, they blamed recently the steroids. Environmental building work. This also I want to tell you. I just want to tell you, you may ask me why you put a building work. If your IC is there by the side of it, there is a construction work is going on. Please remember, your ICU, they have to do the fungal cultures. What is the nature of the fungus which are entering? So whenever you dig the soil, lot of fungi which are there around and all, they will be flying in the air, particularly these molds, and they can infect. So British medical journals have published one very good article. Even a ICU situated by the side of, suppose if we are there always a construction is going on in the hospital. If your ICU is by the side of a new construction area, please take it. And you have to surveillance for the fungi also, not only the bacteria, because a normal person may develop this one with the high density of the fungi. And you see mucormycosis, black fungus was a threatening condition. Then is the incidence of increasing commonest cause of is also because invasive fungus is becoming aspergillus. Recently, there were a lot of reports after the mucormycosis, aspergillosis came into the existence. Symptomatic, you should have a good manual and good operating procedures. And also, people think that culturing the urine and giving a report, this is a great tragedy in the country. To interpret a urine culture is more difficult than getting a degree of MD. There is no doubt about it. Because people don't pay just to see, and also people are carelessly handling microbiology. Urine, you give to the least technician or give to a first year postgraduate and all these things. If you ask me what is most difficult to diagnose is a urinary tract infection, and you take it also because of the improper laboratory services. Many people with a chronic renal failure are because a tragedy happening in an improper diagnosis and not identifying proper thing and a careless broad spectrum antibiotic. Surveillance of intensive care units, I will be just finishing in 5 minutes. So you have to do surveillance for the gram-positive, methicillin-resistant staphylococcus, glycopeptide intermediate resistant, glycopeptide resistant enterococci, high-level aminoglycoside resistant enterococci. Now the enterococci are becoming also more important infections. So gram-negative pathogens, which all I've been told. Now the carbapenems resistance is becoming very important. We have seen one case when I was in Kerala. I just, there was, I think in between, near to the Alleppey, there is one hospital, very famous, a gynecology, this one. See, a lady, a full-term lady, I mean a 7th month, not full-term really, and they have given a meropenem injection just for no reason, and the patient aborted and developed some complications of unnecessary multi-drug. And also we are getting a lot of Burkholderia, that one this thing. These 3 important bacteria, Burkholderia, Acinetobacter, and Pseudomonas, they are becoming real challenge and they are multi-drug resistant. And particularly the Acinetobacter, suppose if you see to the cause of the death from the microbiology or the cultures, it is the Acinetobacters have become, it is a very common organism becoming to the most difficult organism also for the gram-negative. So with the increasing problem of antibiotic resistance, there is an urgent need to improve the overuse, reduce this thing, adoption of such good clinical practices, while efforts are made to ensure prompt this one. Streamline it to simpler, sometimes even oral therapy will necessary. Suppose some patient is overcoming out of the problem, better to think about oral treatment and no antibiotic treatments also. Agree upon a written case definition that is practically given by laboratories. It's for the laboratory surveillance and all. Suppose, see, you got an infection, 2-3 patients infected, the infection control nurse sends a message that you take cultures from our department, I mean ICU. But you take with a proper sense. And you have to define what you got it and how you correlate with the existing circumstances. And a cornerstone of successful hospital infection control. Surveillance is the only starting point and benchmark for assessing the interventions. Effective surveillance involves counting cases and then calculating rates of various infections, analyzing this data, reporting the data in appropriate way of personal involvement. After this, my class, you can look to this one. You just send a sample, somebody comes and put some citriplates into your lab, ICU, and they give the bombarding result. That is not at all correct. And it should be effective surveillance. that they should have the documentation of the past, what happened, how many people got infected with the past, and what is the current rate, how you have made an analysis, and calculating the rates of various infections, analyzing that data. This is very important. There are so many methods are coming. You cannot just find some bacteria. You found some staphylococcus in the settle plate or something. Don't identify fully. Then you say, then they will think everybody has got a staphylococci and treated with some vancomycin or a linezolid. This is what happened really. See, it is any report given by a qualified microbiologist must have it's like a two-edged knife. One means you write an antibiotic, whether it is an infection or not is the first question. Second question is there, if the infection is there, how effectively I am doing it. These are all non-based much plan structure. Unlike scheduled activities, occasional cases of patients who are colonized and infected will trigger further investigation, including, sometimes, one thing is that making a surveillance of a ICU is a very difficult thing. You cannot give a direct answer. So I got this bacteria. You start using the antibiotic. No. It is the only that you have to totally analyze how careful the nurses are there, how much they are taking care about the cannulas and all. A microbiology report is no use at all when you don't use your wisdom. Hand washing, ultimately we are coming only one thing is there at the end of anything. What everybody can do, it is not at all difficult to do. It is the frequency, there is no recommended frequency. Suppose I cannot put a law that everybody wash like an army, 10 minutes you wash their hands. You should use your own correct method is very important. And there is no recommended. And why we fail? Research indicates poor techniques, not all surfaces clean, frequent diminution with the workload. See, if you take a culture from a hand of a person who is in the ICU care, if you really will be worried, what are all the things that particular nurse carrying on? Anyhow, they are putting a gloves. There are so many types of gloves and very least expensive also they are using. Just to throw it every moment and all. And these are all the references I have taken. Ultimately, I want to tell you, hand washing is the most important, particularly when there is there are no much taps are there. That is a very much concern. And when then there is an alternative is the alcohol based. Research indicates poor techniques, not all surface. This is very important. Ultimately, they made hundreds of cases of the infection in the ICU. They found out that they are doing a very cursory hand washing. See, hand is a very complex. You have got 5 fingers, some ridges and inside, and see that this picture contains 6 pictures. Unless you put into the action for 20 minutes, it is a certain thing that will reduce. I don't know whether vancomycin will act effectively in that time or not, but hand washing will certainly make another person safe from the infected person. This is a very important message. So if you want all the people to be safe in the ICU, please wash the hands. And why working in the high risk areas is because you cannot go for hand washing very frequently. They will say, if a nurse goes away for 10 minutes, the doctor may shout that you are not following, but she has no time. Lack of hand hygiene promotion. There are so many weeks are done in swings like that and all, that we have got 1 week. Johnson & Johnson was sponsoring a lot of programs about, this infection prevention week. Nowadays, everything had disappeared because everything has been on lack of role model. The HOD won't wash their hands. The surgeon thinks, why I am a surgeon, I will do whatever I like, I am the genius. But he is not the genius, he is more dangerous. At the end of the story, he may do a beautiful operation. After sometimes he will die in the name of that role model doctor who is not. Lack of institutional priority. You go to this one, why, what is this now, doctor? You are not, I want some concrete solutions, not this hand washing. You go to the medical superintendent. Lack of sanction of non-compliance. So you know very well, lot of shortage of masks was there, gloves was there, cannulas was there, everything. These are all not to be discussed in public and you know very well of it. And documentation, you should do it. Suppose every month you should document central line associated infections, catheter associated infection, surgical site infections, hospital onset, Clostridium difficile is very less in this country as such. but we are not having because we are not culturing in our hospitals. It is a very difficult thing to diagnose because they have to do some talks. Hospital onset methicillin-resistant staphylococcus and bloodstream infections. So at the end, we all live by counting little money. You take 80-90% of the people doesn't have any proper insurance, and poor people. And one thing, COVID has made many people poorer than any other disease, poorer resources. And who will pay for all these things? Suppose somebody has, there were some stories. What are all the errand that is all gone to the hospital? Think about it. Epidemiology, maintenance of prospective core and this one. So now it has gone into the community medicine. So you should have a good friend in community medicine. You can have a good statistics. So multi-center prospective study was taken in 46 hospitals along with a very long time back, India, Morocco, Turkey. There are so many projects are coming. One thing I want to tell one thing. You read a journal, but we just read and for the purpose of getting a degree or writing a thesis or this one. But we are not emphasizing a very good important point in the journal to many people. See, I just want to tell you, I not worked in a very good setup, but I worked, I became my own master there and all, because we cannot change the people around, very difficult. And you can, I decided, it is very difficult to few people around you to change to good compliance, but we can change many people in Africa, Gulf and all these things, because when somebody is there, because once we are graduated, have a very good qualification, we think that we are the masters, but microbes doesn't care your degree, whether you are MBBS, PAC or a super specialist or a genius or a Nobel Prize winner. This is a one thing is there, microbes are the above all of us. That is what it COVID has proved. Still it is proving. Till all ours are ideas only. No concrete thing has come. Now the epidemiology of infectious disease has totally changed with the COVID. Please go through this one. It is not just some few slides cannot make. Our vision. Programs must maintain training records of the employees. The minimum training required in OSHA, bloodborne, universal precautions they were bombarding during the AIDS. Then nobody is bothered. 90s, it was the most, this one. So why we need ICUs for an instance as well as for prevalence? There is no window critical. See, staff training a great priority. All staff, I tell you, train 100 nurses, one doctor against 100 nurses is very important, because the first person who puts a cannula when you enter into the casualty is the nurse who comes in a hurry. So you see, the infection starts at the stage to a patient who is coming. You go to a normal person, you say, you go to a casualty in a hospital and that I got a reading, and they won't even talk to you. First they start a drip. This is where the infection is starting into a person. And the person who is putting in a hurry will be causing pain, wrong, this thing, improper hand washing. And so, I mean that what I mean is there a normal person, I go for a headache or really, they put a cannula, IV cannula. That means today you have got a vertigo and tomorrow you got a bloodborne infection. This really happens. We cannot criticize anyone, but we have to look to ourselves. What is our role? So critical care in India has evolved very rapidly, and now I am very happy. Many of my students, they have gone to the MD critical care and emergency medicine, and they are doing fine. So ultimately, I told everything. These are all the repetition. Once again, this thing. So published data, nation of India is lacking. What is needed is the process. So a conscious regarding the concept of medical right to live. See, one thing I just want to tell in a free sense is, so there were a lot of questions also. Even the courts are approached. Who is that? There was a case. Anybody goes to the hospital, they are putting on the ICU with a little of this side or that side. So even the courts cannot decide. It has gone to the, even up to the, I think to the best of the highest court, when to be admitted in ICU. People say that they are exploiting to putting it. These are all the legal matters. So it is, the one thing is there. See, about the controversies about the admission in the ICU, you are all practitioners. It is a right to live. Suppose you cannot deprive a person of a ICU, but at the same time, you cannot force into a person into a high hospital to keep him to the best hospital, because they don't admit unless there is a. You see, recently in COVID, unless you deposit lot of lakhs of rupees, nobody is admitted in many good, very, very, very good hospital. This all means, see, this either if you take money is above everything, life and death, that we all know very well today. Then, so these are all best solutions are few. There are so many challenges, but solutions are very few. Ultimately, your life depends upon these two people around this one. Leave alone. If they are sincere, we can live this one. So, and I just taken this topic as an interest. It is not that one. We all may need one day ICU care. Even if you don't need, even our near and dear may need ICU care. I always put the things, you all should be think for the future. It is not that you don't do anything. I am retired and I am at 72 years. What is the need of talking to some people when given an opportunity? So it means not that one, we are creating better professionals, better patients to prepare to the situation, and excellent nurses to achieve this one. So let us give everyone a clean hand. So employees must stand before returning. This is a one thing. Whenever somebody goes, some places I put it this board. Whenever the patient is there in that Chartala, there is a one nursing home where a sister was there and all they are putting. Whenever you go out, you please wash your hands. It's very important. I thank everyone. What is the pathophysiology of the mucormycosis in ICU cases while infecting is on it? See, this is a very strange phenomenon which entered in the black fungus was there. It is not new at all like that one. See, in Swins, when I was working in the super specialty hospital, see, there were so many deaths even associated in the final stage of the HIV and all these things. Mucormycosis is a very fast spreading infection. Suppose it is there in the nature, even in our nose, it may be, we are inhaling mucor also. Mucor is one of the common contaminant of even the good air we breathe outside when you don't have, even mask also. Mask, there is no much this thing and all. So it may be whatever it is there which is non-pathogenic, it has become pathogenic. One reason may be the high doses of corticosteroids and also the high antibiotics which we are using. That means certainly it needs a lot of study because it has come like a flare and also reduced. Then they put a lot of colors, black fungus, white fungus, and all these fungus. So it is not that when even many leukemia patients die at the end with not with blood dyscrasia, but finally with the fungal, this one, it is always there. How you make it is, see, fungus, usually, please take it, one thing about the fungus is there. Fungus don't infect anyone unless there is a predisposing condition, as with the diabetes, as with the corticosteroids. And also this corticosteroids, not excessive, I cannot say the clinical decisions is correct or not. So they're given the drips and all these things, they're given 2 to 3 antibiotics and all. That may be this thing. There are a lot of articles, controversies about mucormycosis. Anyhow, it has come down. I think if you take it about 2-3 months back, it was the most talk of everyone. Now today it is much less.
Shakti Srivalsava from Uttar Pradesh. So he's asking treatment of bed sore infection.
Bed sores, I told you a picture there. One person is turning on this thing. You suppose somebody is lying on the back for a long time, the friction, whatever it is there, the renewal of there will be a lot of friction between the place where somebody is lying. Usually they are putting some rubber sheets and all these things that causes erosion of the superficial layer and causes the bed sores. Please also remember, you see, you take to the health of a skin of an elderly person is very fragile, dryness and all these things. And superficial erosion of the layer will lead to the bacteria, and the most bacteria which is present around any of us is the staphylococci or a pseudomonas. A normal thing, pseudomonas, you may not produce an infection, but if there is a little friction there, there's a lot of erosion of the epidermis of the skin, still they can cause infection. Once you get a bed sore, life is the real miserable. Not only that one is the obnoxious smell, one is there, and the totally and fearful situation also there. Nowadays there is a lot of thing is there. There are not a lot of, when you take Kerala and all, lots of plastic surgeons are also assisting this one and to reduce the grave condition. So it is wait and watch, not a wait and watch in reality, and you have to watch for the bed sores every day. Suppose it's something which is very small, 1 millimeter or 1 centimeter lesion, if you are not turning the patient, you can't see the things and it goes into a very big tragedy after some time.
So, doctor, the next question is from Dr. Nagabhushan D. From Andhra Pradesh. He's asking, clinically, how to suspect which organism is the cause for sepsis?
No, there is, see, by clinically, you cannot decide. See, if you can decide cause of the bacteria, but you take a Pseudomonas is there. Suppose I tell you a simple examination. Because one thing I told you, look to this one, common sense in the situation of the instant said, when you are dressing a patient and you find a green colored bandage there, certainly it is to be identified as a Pseudomonas, because some Pseudomonas produce pigmentation. If you are just see a yellow colored bandage, that means a Pseudomonas. But if you take many organisms, you cannot identify, because see, sense of smell also you can find out. Sometimes, this anaerobic bacteria, if you enter into a ward, you find a very deep, disturbing and very foul smell. Take it and not to forget anaerobic bacteria. They are more dangerous. So our own smell, a vision, common sense, ultimately also some of these, our own senses, we can find out. But if you take to this one, you find, and suppose in a wound is there, you drained an abscess. It may be green colored, you can say Pseudomonas. Sometimes even the Staphylococci also produce some pigments. But one thing is there, by just identifying an organism, you are not doing justice to the patient. You have to send for culture. And above all, you have to find out the antibiogram, which antibiotic is effective, which is not effective, what is the antibiotic which he is taking. Suppose if you get the same 3 to 4 type of the cases around, suppose you take a burns ward and you are fighting 3 people around the cross-infection Pseudomonas, that means there is some lacunae in cleaning the area or some bad quality of nursing. They all can be diagnosed. Just by seeing a sepsis, you cannot make it. Because now also I just want to tell an extended thing. They found out giving aggressive treatment in sepsis is also can be dangerous. Suppose you got a sepsis, you want to kill all the bacteria, bactericidal drug you have given. See what happens when you kill all the bacteria, they liberate endotoxin. And this endotoxin can kill the, produce the multi-organ failure. You all know that endotoxin, there are a lot of treatments. There are some people with the sepsis, they give a very progressive way. Previously, there were some aminoglycosides are given, and tobramycin they found out it will reduce in a gradual way. The death of the bacteria, suppose if you are going to kill 1 million bacteria, it will be producing so much nanograms of endotoxin. So there are a lot of therapies are also monoclonal antibodies. Suppose you may think I have given the wonderful antibiotic. It is not the end of the story. It is only the beginning, and the patient may die with the toxin. Yeah, because of the every gram-negative bacteria, many at least, produce liberating endotoxin. When you kill them, one problem. When you don't kill them, another problem. Now this is a very expensive therapy, monoclonal antibodies and all. See, one thing, a patient in a sepsis can survive if there is a coordination and the wisdom of the clinician. Thank you very much.